Good morning. Good morning. Buenos dias. Good morning. All right, we are going to get started. My name is Cristo Luna, and I am the CHCI AHIP Health Graduate Fellow this year. I'm delighted to be with you here today for Promoting Latino Heart Health breakout session. A little personal story. I think heart health is so important. My grandma literally got a stent the other day in her heart because she had no idea. She had a heart murmur, high blood pressure, and it's so important to get these screenings before you're 90 years old. So I think we're going to have an amazing discussion today. On behalf of CHCI, I would like to thank Amgen for their generous support of this session. It is now my honor to introduce welcoming remarks from the chair of this panel, Congressman Darren Soto, the first Floridian of Puerto Rican descent to serve in Congress. Congressman Darren Soto was elected to the U.S. House of Representatives in 2016 to represent Florida's 9th Congressional District. In his first term in Congress, he passed the most laws of any freshman member in the House. Now, in his third term, he has established himself as a strong advocate for the environment, hurricane relief, emerging technologies, and much more. Congressman Soto currently serves on the House Committee of Energy and Commerce and the House Committee on Natural Resources. Additionally, he is the chair of the Future Forum Caucus, whip of the Congressional Hispanic Caucus, and a proud member of the New Democratic Coalition, Problem Solvers Caucus, Congressional Progressive Caucus, and LGBT Equality Caucus. Please welcome Congressman Darren Soto.
Thank you for that generous introduction, and thank you to CHCI for all you do to help host interns across the nation. We know this is all about the future of the Hispanic community. Thank you to Amgen. I see my good friend Howard there for helping sponsor the event today. Look, when we're talking about the Hispanic community, the leading cause of death among us is from heart disease. It's from issues related to the very topic we're talking today. So it's really important that we have these conversations. When you think about the progress that's been made over the last 20, 30 years, particularly with regard to not only invasive surgery, but even more importantly in statins, which our pharmaceutical companies led the way on to help extend millions of lives in the Hispanic community. When we think about Social Security and Medicare, where they capped it at 65 years of age back in the day, that was because that was the life expectancy. And now if someone passes away at 65 years of age, we say, oh, they were too young. It's so sad. But that's a testament to the innovation in our nation. We also were very pleased. I was in the state legislature at the time to see the Affordable Care Act passed 13 years ago, because that's critical. Pre-existing conditions, having a heart attack or having certain conditions related to high blood pressure and cholesterol could have blocked you. That seems like long ago, but that was something that happened just a few years ago. And we know how important it is to have coverage and to have these types of medications. The pandemic taught us that all too well, because those with pre-existing conditions, particularly those with heart disease, were more vulnerable under COVID-19. How many stories did we hear about young Hispanics in their 30s or 40s passing away from COVID, leaving young children behind, or leaving a widow or widower behind because of that? So we know we have work to do. Also, being on the Ag Committee, in addition to the Energy and Commerce Committee, we have healthier eating to do too, but I'll leave that for another time. Just recently, we've passed a whole slew of laws to help in this area. As we were fighting to get out of the pandemic, we passed the American Rescue Plan, which was the first effort for what we call the ACA Enhancement Act, which extended subsidies to many folks in the middle class who otherwise couldn't afford health care. It provided $27 billion for health disparities. And in a similar bill that passed at a similar time, we passed the Families First Act, a few years earlier, which provided for telehealth, which also critical, especially for our seniors and for those living in rural areas. We also, through the omnibus this past year, did everything from extending Puerto Rico's Medicaid parity, as with states, allowing FDA to take a series of actions to increase diversity engagement in clinical trials, the ARPA-H, our advanced health research, among other key issues like extending telehealth for another 2 years. We also passed the Inflation Reduction Act, which, as of 2025, will cap the amount that seniors pay at $2,000 a year out of pocket. We saw an insulin cap that started this year in January of $35 a month. I applaud private sector pharmaceutical companies for stepping up and meeting that price for everyone and answering the president's call. I had Secretary Becerra in our district in Meadowwoods just a few weeks ago, and we got to not only have a senior talk about now having lower insulin costs, but also a young woman who couldn't have been more than 13 or 14 years of age, someone with type 1 diabetes and needing that medicine for the rest of her life. In addition, we have a couple bills we've already co-sponsored in the 118th Congress, access to automated external defibrillators act, which will be key to make sure we continue to have access to defibrillators in elementary and secondary schools, among other areas. The Health Care Affordability Act of 2023, which makes permanent these tax credits to help the middle class be able to afford the ACA. And then just recently, with the end of the continuous coverage requirement during the pandemic under Medicaid, we saw 1 million Floridians and millions of Americans be dropped off of Medicaid because they were no longer required. Now, they weren't eligible anymore, but during the pandemic, it was prohibited to kick anybody off. And so I was proud to lead a letter with many CHC members on energy and commerce and others to Secretary Becerra to request a special enrollment period for all these folks who are being kicked off the rolls of Medicaid so that they can get onto Obamacare, and we've seen that be successful. The last thing I'll end with is, so where's the future of this? Of course, there's healthy eating, which we all should think about doing. When I think of like what I'd eat when my abuela would cook a dish, it would be rice and beans and plantains and potatoes and then a little bit of chicken and a little bit of salad. That's arroz con gandules is a very common dish among us Puerto Ricans, and I don't know, we all have our dishes, but it shows like it's a little out of whack, right? We need to eat a few more vegetables, more proteins, and this is something that I know we'll talk about it another day. It's the obesity drug research that I think is one of the most innovating things in this space right now. We have seen that some diabetes medication have upped in dosage. It's not fully approved yet, and so this is more as prescribed, have been able to reduce obesity. We even have things on TikTok like the skinny pen, where people went crazy over the Ozempic pens, which is not good because we need those for folks with diabetes. But it does show that there may be pharmaceutical solutions to obesity as well as exercise and healthy living. So I look forward to the panel today and the discussion, but there's a lot of exciting things in innovation in healthcare and in the pharmaceutical industry, and we appreciate the discussion today. Welcome, everybody, to Washington. Appreciate you all.
Thank you, Congressman Soto. It is now my pleasure to introduce welcoming remarks from Roberto Monserrate Maldonado, the Director of State Government Affairs, Puerto Rico for Amgen. Roberto oversees healthcare policy development and lobbying before the Puerto Rico legislature, the executive branch, and key government agencies on behalf of Amgen. Please welcome Roberto Monserrate Maldonado.
Thank you. Thank you, Congressman Soto, for all your help. We really appreciate any help. Puerto Rico obviously needs a lot of help, and we are happy to be here. Amgen is a very proud sponsor of CHCI, including the Congressional Internship Program, which brings more Hispanics to Congress. And that's important, as having more representation is extremely important in diversity. We also are very touched by cardiovascular disease. Probably everybody in this room has been touched in any or some ways by cardiovascular disease. Myself, not only my dad, but my mom, both high blood pressure and high cholesterol. Unfortunately, my mom passed away 2 years ago because of a heart attack, and my dad suffered a stroke, which left him bedridden. So very close and personal. But we are here precisely, and thanks for CHCI for making this discussion possible. I think we need to do more together. Amgen certainly is committed to better health for Hispanics and for everybody. Better access to medicines that are life-saving, life-changing. So this discussion is extremely important. We need to have more awareness, right? They say it's the silent killer, high blood pressure, and that's the way it happened, right? Both my mom, my dad, even though we are, people that we should know better, we have to take care of. If we don't go to the doctor at least once a year to get checkup, we will never know, and it's very dangerous. But overall, Hispanics, about 60% of Hispanics, adults, have high cholesterol levels, and half of them don't know it until it's too late. So this discussion hopefully will bring more awareness, and please share it with your friends, your family. This is something that is can be life-changing. And this is a very complex, as you know, very complex issue, right? It's not solved by one entity. It has to be government, private sector, and experts like the ones you will listen to very shortly. At Amgen, we partner with many stakeholders, including the National Hispanic Medical Association, the Partnership to Advance Cardiovascular Health, the American Heart Association, and the Association of Black Cardiologists, just to mention a few, because this is a complex problem that needs a complex and difficult way to end it, right? At least make it much better. The health disparity is a problem. We have more Hispanics, and it's growing. I mean, instead of decreasing, the problem is growing, and so it is something that we need to talk about. So thank you for the opportunity. Thank you, CHCI, and we look forward at Amgen to continue helping fight these terrible diseases. Thank you.
Thank you, Roberto. It is now my pleasure to introduce today's moderator, Amy Hinosa. Amy is the president and CEO of MANA, a national Latina organization, the oldest and largest Latina membership organization in the United States, and its sister organization, MANA Action Fund. MANA focuses on empowering Latina women and girls through leadership development, advocacy, and community service via educational programming for adults in the areas of financial literacy, professional development, and mentor training. As a representative of MANA, Amy currently serves on the board of directors for the Hispanic Association on Corporate Responsibility and the National Hispanic Leadership Agenda. She is the secretary of Lideramos, an organization committed to elevating the quality, content, and reliability of nonprofit Latino leadership programs. For all her great work, Amy was named one of the 2022 Social Impact Women to Watch by Nonprofit HR. Please welcome Amy Hinosa.
Comments. Thank you, Congressman Soto, for your championship of health issues, especially as they relate to our community. There are nuances that we know to what's happening on the ground with our communities, and we need champions like you and the caucus members who really make sure that those conversations and those issues stay top of mind. And I'm so thrilled. Thank you so much to CHCI, to Margaret Davis, the incredible team. Thank you to Amgen. Wenta, thank you so much for the invitation to be here. We're proud to be part of these conversations. At MANA, we believe that when you help women, you help families, and that's really why we want to be at the core of conversations like these. But I know you're not here to hear from me. You want to hear from this incredible panel of experts who are really on the forefront of all the conversations as they relate to Latino health, because I think we all learned this powerful lesson through the pandemic of how all of these issues, how our personal health, how our heart health in particular, really could have made significant differences when we were hit with something as tragic as the COVID pandemic. And so we really want to talk about how we take those lessons, how we take those experiences, how we move forward, how we keep health equity top of mind, especially when we're talking about heart health. And so please help me welcome to my left here, Dr. Karen Mancera Cuevas, Senior Director, Health Equity for the National Health Council. We also have Magnus Oman, Vice President of Global Development for Amgen. Welcome. We have Christine Perez Jimenez, Programs Director for the National Hispanic Council on Aging. And at the end, we have Dr. Eduardo Sanchez, Chief Medical Officer of Prevention at the American Heart Association. Many thanks to you all for being here. We're looking forward to the conversation. So let's level set and start it off. And let's talk about why, I think when you work in a space sort of, within a Latino space, people always ask, why? Why Latinos? Why should anyone even care about Latino heart health? Karen, we'll start with you.
So I would say, as someone who has been very integral to National Health, Lung, and Blood Institute studies and has worked with Latino cohorts and Latino participants, cardiovascular health is very important, not only when it comes from the research lens, but also from the educational lens. Really talking to Latino families, engaging them. A lot of the conversations earlier today were talking about patient engagement, but also it's relating to patient advocacy. And a lot of individuals within the Latino community really need to hone in and understand what are their risk factors, how they can access services, but also what are their rights within understanding the whole cardiovascular realm.
Well, and when we talk about cardiovascular disease, we have to remember it's a preventable disease. We can do very well if we actually manage our risk factors for heart disease. You heard them already: hypertension, high cholesterol, exercise, good diet. All of these things are available to us. One of the challenges, of course, as the congressman mentioned, should he really give up his heritage food? Well, I think maybe not. Maybe we should help by having medications that can bring about a change. And for us, who actually work on developing these medications, it's very important. I've now spoken for about 90 seconds. You know that one patient just had a heart attack. Every 90 seconds in this country, somebody has a heart attack. And we need to do better. And there's lots of things that we can do to do better.
Thank you.
Yes. Well, at the National Hispanic Council on Aging, we continuously work to improve the lives of not only Hispanic older adults, but also their families and caregivers. And one of our priorities is health. And we know and believe that all older adults should age in the best possible health. And this includes being healthier, right? So as part of our work, it's important to take action and also educate our community about what's heart disease, like going to the basics, like 101, what is heart disease, what are the risk factors, and moreover about prevention. We tend to forget about prevention, and like Magnus mentioned, this is an essential part to prevent cardiovascular diseases among Hispanic or Latinos. And I want to end, like, if we want to older adults to age well and healthy, we need to empower them. And not only the seniors, but also provide educational information in a culturally and linguistically appropriate manner. And moreover, also invite family members and their caregivers and the healthcare providers to explain them better what's cardiovascular disease, what are the risks, what are the prevention. So it's all about a holistic approach that we all need to provide when involving Latino heart health overall.
Thank you. Dr. Sanchez?
So I think, Amy, your question was why? Somos 20%, 20%, almost 20% of the population of the United States is Hispanic Latino. That percentage is going to increase. I live in a state where 40% of people in the state are Latino Hispanic. California, 40%. New Mexico, 50%. 60 million people in this country identify as Hispanic Latino. That's one reason why. Two, in addition to what's been said, of course, prevention. I'm gonna add to the list. You see on my lapel a number 8. These are the 8 modifiable risk factors to prevent cardiovascular disease. Sleeping plenty, eating healthy, being physically active, not smoking, having a healthy weight, healthy blood pressure, healthy cholesterol, and healthy blood glucose. If you can do that without medications, fantastic. And there's opportunity to do that among the entire population, including Latinos. If you need medications, fantastic. Last thing I'll say, actually 2 more things. One, we have the highest uninsurance rate in the United States of America. Almost 20% of Latinos do not have health insurance. And the great things that one could access, even including counseling on how to be healthy and medications, only comes way better when you have health insurance. I live in a state where 30% of working adults do not have health insurance. Last thing, just in the realm of physicians, only 6% of doctors in this country are Latino Hispanic. And in any one of the health professions, we will find that there is underrepresentation and opportunity to do better. So I would say fixing the workforce, modifying that workforce to look like us, talk like us, be receptive to us is critically important. That's why.
Absolutely. And I want to stay on that thread of communicating it amongst ourselves. You know, Roberto, you talked about your family's experience, and you know, it resonated with so many of us because I think we almost all in this room have, if not a similar story, know someone who has a similar story. And so when we're talking about communicating to Latino populations, right, it's not just an ad campaign. It's not just something basic. How do we start talking to our families more in depth about those risk factors, about those lifestyle changes that they can start making? So Karen, I'll start with you and ask anyone to jump in.
I think that there's like a lot there that we need to start thinking about. I think that it's risk factors, but I think it's also culture. Culture overrides a lot of when we talk about, I'm a public health person in training, and in my background, we need to think about behavior change. Behavior change is really difficult to be able to circumvent when we're talking about culture and that role of culture, which impacts in cardiovascular disease, lifestyle, nutrition, environment, social determinants of health that are multi-layered. We need to think about how then when we talk to our populations, how we're trying to talk to them about behavior change. Because if we try and remove all of these other realities that these individuals are going to, you can't address the core problem. So that is really part of the implicit change that we need to think when it comes to cardiovascular preventive measures, and then how do we circumvent around changing those measures.
Magnus, as someone who works in the pharmaceutical industry, what is something that you just wish people knew and acted on in terms of their risk or their lifestyle, so that maybe one day you might not have to work on that, that type of medication?
Yeah, I mean, so that's inherited conflict, right? But having said that, my dream would be that we would prevent cardiovascular disease by whatever means, as Eduardo says, risk factors, but also through medications. Now, one piece here that I want to bring up, and that is you say, well, we've worked on heart disease for 20 years. Why hasn't it not got better? Well, the reality is that people are not actually getting themselves looked after. Part of it is access, part of it is other issues, part of it's perception. I'm too young to have heart disease. Like, how many times have you heard that? And so this issue is an important one. But I think the other part that we keep forgetting, and it came up here earlier a little bit, we have an emerging diabetes, obesity challenge. With that comes heart disease. And so we need to actually look at this more holistically and say, what are all the things that we can work on? So as somebody working in pharmaceuticals, I can say, we're working on it because we want to fix this, not only your cholesterol, but also other risk factors such as obesity and hypertension and so on.
So Christine, for you, with the aging population, how does that messaging change with elder Latino populations, right? What are the conversations you want to have with community and want them to have amongst themselves?
Yes, absolutely. So first, as I mentioned before, I think it comes with the healthcare providers, and eventually, for example, in our housing facility named Casa Iris, is located here in Washington, D.C., provides home for seniors with low income and that live independently. And we always see people knocking our doors, like seeking for services. And they're like, Christine, I just cannot call my doctor to make an appointment because I don't know English very well. Please help us. And we are there to help them and assisting them in calling or scheduling an appointment. And sometimes we have seniors that are like, Christine, please make sure to have an interpreter with us in the medical, appointment. And it's part of something that we are very concerned because we need to understand that Hispanic and Latinos are not monolithic. So we have different, terms and language. We speak Spanish, but different terminology for each country, like for Puerto Rico and Venezuela, Mexico. So for us in the National Hispanic Council on Aging, we have bilingual staff, and we have the Social Connector program, which we connect seniors with health and social services. And it comes to that when we need to help them in scheduling appointments or talking with their medical providers, like, for example, a cardiologist, and we make sure that not only the patient, that is the people that we are serving, but also the healthcare providers know the situation, that she only speaks Spanish. And we need to also consider that with healthcare providers, most of them only speak English, and sometimes we know that we need for them to be trained in a culturally and linguistically appropriate manner to deal or to work eventually with Hispanic and Latino seniors. And I just want to end that we tend to forget about the caregivers. And we have caregivers that they only speak Spanish too. So we are helping not only the seniors, but also the caregiver. And we do it, with any problem. But that's something that healthcare providers should be aware of.
So, Eduardo, you mentioned, the 8 basic things that folks need to be aware of, and they sound so intuitive, right? You're saying it sounds familiar to everyone. Yet we still have barriers for why there's so much heart disease, because there's a gap there, right?
Yeah.
Whether that is personal responsibility, whether that is access to treatment, whether that is understanding care, access to medication. Talk to us about those barriers and how we can think about, in terms of solutions, how we get to the right answer.
Happy to do so. So a couple of things. One, we can embrace culture to reach that healthy place. And the truth is that there's research being done right now. There's a researcher in Harvard. Her name is Josimar Mate. She's doing work. I'm going to use this term. It's not her term. The Puerto Ricanization of the Mediterranean diet. So the thing is, Congressman Soto actually described a healthy diet. Yeah. There was nothing that he talked about there that's not healthy. And what Dr. Mate is doing is beginning to find those things that are the culturally accessible parts of the diets that we eat. Another one is the Dieta de la Milpa, which is the diet that the Mexican government is saying is a healthy diet. There's nothing unhealthy about Mexican food unless you eat it in an unhealthy way. So embrace culture. The other thing about embracing culture is, last time I checked, Bad Bunny, as an example, was the most popular musical artist in the world. And last time I checked, and think about my family, bailando is a thing we do. So you don't have to go to Planet Fitness to get physical activity.
Right.
You just need to turn on some music and move your body. So
I need for somebody to tweet that.
So,
I mean, come on.
So if we can begin embracing culture and leveraging that rather than saying, put on clothes that don't look good or that you spend a whole bunch of money on to go to a place where you're embarrassed to be. Because the thing is, last I checked, Latinos, all shapes, sizes, and everything, will mix it up on a dance floor and don't worry too much about what that other person is thinking. So, just saying. So some barriers.
Amen.
So there are barriers, though.
Yeah.
And I am somebody who believes, having been a clinician who took care of patients in federally qualified health centers in Austin, Texas, that are designated federal places to provide care for people who are uninsured and underinsured, the desire is there. So I don't like to talk about personal responsibility, because that's just a matter of having a conversation and saying, here's what you can do. Here's what you can do. And then we need to take into consideration, though, context. And that's where the barriers are. So if you live in a neighborhood where there are no parks, hard to be physically active at a park. If you live in a neighborhood where there are no stores, it's really difficult, grocery stores, because there's probably liquor stores or dollar stores, and there's nothing wrong with them, but they're not grocery stores. You don't get fresh fruits and vegetables at either of the other two. And if you live in a place where getting to the doctor, where the doctor doesn't speak the language or accommodate you as a patient and welcome you, even if it's there, you may not go. So, and those barriers are sometimes associated with lower income, associated with poorer schools in those neighborhoods, which perpetuates the very kinds of situations that we're trying to overcome. So, kind of complicated, but it's the reminder, I think I heard say, this is multi-sectoral. We need to be thinking about, how do we get people into medical care and the right thing get done? How do we address those social factors and social needs that get in the way, both at a individual level and at a policy level? So this is great that this is a congressional caucus, because some of those solutions are ones that are going to happen in the government sector. And we've got to figure out how we can also make sure that schools are delivering quality education and graduating our young people out of schools at the same percentage as other groups in our country.
Absolutely. So Karen, I want you to kind of piggyback on that, and in a solutions-focused way, how do we get to that point?
I think that we get there through a lot of it is pipeline programs, right? I mean, education, that is key. I mean, we talk about it, but then the ways to get there are challenging. But there are novel solutions that are occurring at the community level. But I think that it's also finding piecemeal solutions. I'm someone who historically in my career has worked community level. Every community is very different, and every Latino community actually has a lot of their threads and intricacies and their strengths. I mean, we're not talking about the fact that our Latino communities have strengths. We have family, we have community, we have church, we have religiosity, we have partnership, and we want as a community to succeed. So we really have to drill down to the community levels, work with our community-based organizations, lift it up small, and then get to the masses, because again, we are one of the largest populations growing in the United States, but we need to build capacity in order to get there to make our communities more healthier.
Absolutely. So Magnus, I want to come back to you, and we have so many answers, right? And we know what we should be doing. We know there are medications out in the market, and we still see so many of our folks dying or having massive heart attacks, strokes. Where's the gap? Why are we still seeing, with all the things we know, how do we still have these terrible numbers?
Yeah, it's a great question, and I want to sort of echo a little bit what Eduardo says. Part of this is education. I mean, I look around the room, most of you are relatively young, but I'm going to ask for a show of hands. How many of you actually had your LDL checked last year or this year? That is remarkable. You are actually a self-selected community, because if I did this in North Carolina, anywhere, it would be maybe less than 20%. So therein lies the problem. If you don't know what you have or what's going on, how would you then ever prevent things to happen? So for me, that is one of the more fundamental things. And we need to work, but recognize that physicians need a little prompt occasionally. Ask the question, can I check my LDL? Can you check my LDL? It's allowable, and it's paid for if you have health insurance. But it is basically something very simple that all of us can do.
Right.
Can I just jump in?
Please.
I completely agree. You can go online, mylifecheck.org, or go to the American Heart Association. You can check your how you score against these 8. But the truth is that that's an assessment that ought to be happening in a clinical care setting. And I'll just underscore that for the millions of Latinos without insurance, getting that done, that is a barrier. That gets in the way. And would also agree that knowing these 8 puts you in a position to say to your doc, is my blood pressure at the level it should be? Did you check my cholesterol, and where can we get it? What can we do about my blood glucose? And I'm interested in managing my weight. What are some ways that I can do that?
So from, I'm hearing the conversation, and, Christine, I want to go back to you because your organization works with folks on the ground. And, you described all of the different folks that you need to work with to sort of get everyone rowing in the same direction, and then layer on the language barrier, right? As we think about it, we're talking to a room full of advocates, right? As we're having conversations about what the solutions are, what's missing in terms of whether it is funding, whether it is support, whether it is even knowledge of what is needed to really do that work on the ground?
Yes, that's an excellent question. And absolutely, we cannot do this work alone. And that's why we always partner not only with community members, but also with promotoras de salud. And promotoras de salud are community health workers that actually they know their people, they know where they are, they know their issues in their respective communities, and are trusted messengers in their communities as well. So promotoras are essential for us in providing the information, just the basics about heart diseases overall. And sometimes you have the community coming up to them and like, please explain the terminology, or what are the risk factors, or I'm Mexican American, but I don't know that exercising might help me. And because sometimes, we due to the pandemic, we live, our world changed a little bit, let's say it like that. And we became more sedentary, like not going out or just doing everything in the internet. So that's something that for us, and not only Hispanic and Latinos, but the population overall should be aware of. And that changed a lot, the story, right? And with obesity, high prevalence of obesity among Hispanic and Latinos. So overall, coming back to the promotoras, they are well trained and they also speak Spanish. That's a plus for us and for everyone who wants to work with promotoras. And you can do that by reaching out to the community and reaching out to community-based organizations that can connect with promotoras de salud or have a program with them. And yes, I think also a partnership is essential with other funders. Always it's good. And just keep the conversation going and take action. That it's very important for us, because sometimes we tend to just talk a lot about it, but then we don't follow up with the community. Like, are you doing the exercising? Are you eating well? So that's something that also we need to consider, like following up with the community after we provide the information.
Yeah, and from the community vantage point, sometimes we have to communicate upward. Magnus, you and also Eduardo, you both talked about your screenings, your LDLs, and actively asking for those. We know that CMS didn't include the quality measures related to lipid screening in its most recent prioritized list of quality measures. So folks who maybe are on Medicaid may not necessarily be able to, well, they might have to ask for them, they might not be covered, they might, there are lots of little traps along the way. How do we stress to the federal government, to CMS, that these are absolutely needed and can really save lives?
Well, I'll give my thinking here, but Eduardo rightly has access to this also in a more different policy way. But generally speaking, how do we make people aware that lower LDL is better? Well, the science has been published. Doctors ought to know that. We have practice guidelines that are used by physicians and who guide them of the best practice. And they are sort of gradually changing. Last summer, we had some update on the guidelines suggesting that the lower LDL value is much better, and there are ways to get there. On the bigger policy issue, I think I have to pass to my policy knowledge friend Eduardo, because in a way, the science is moving. Policy tends to be a little bit delayed.
So the American Heart Association has a fairly active advocacy/policy change apparatus, and I think that's the right word. We'd love to have many, many more people. We try to engage ourselves in collaborations that are trying to do work to influence, to inform and educate policymakers. That's the right word. Influence is not the right word. So scratch that word. We also, and so whether that's around CMS policy and quality measures, no doubt in my mind, AHA had a viewpoint there. But just in the past few days, one, we submitted comments regarding the U.S. Preventive Services Task Force recommendation that all pregnant women should get their blood pressure checked. We say yes. We are engaged in providing guidance around the school nutrition program to make sure that the foods that are being served in schools are lower in salt, lower in sugar, and have more mixed grains than not. And believe me, that can be done in a way where kids aren't going to say, ooh, gross. Or if you think about yourself and your childhood, all the food was ooh, gross. So you can see it either way. Sure. And we're also involved in very strongly advocating for the Farm Bill, because the Farm Bill under USDA, like what's AHA doing there? When we talk about context and upstream, the school food programs are funded through that bill. The WIC program is funded through that bill. That would be women, infants, and children. That's a program that serves healthy food to pregnant women and then young children early on in their lives, low income. It's the program in which SNAP is housed. That's the Supplemental Nutrition Assistance Program. So we are actively not only involved in, but doing surveillance about where are those opportunities where the AHA voice can make a difference. The last thing I'd say is that we as an organization write some of the guidelines that talk about the what needs to be done to control blood pressure, to control cholesterol, and we use that foundation of science to back up the positions that we take and the way we go about informing and educating.
Absolutely, and you're right. With influence, maybe not the right word. At Mana, we say we change hearts and minds.
Yeah, others influence, we inform and educate.
Absolutely, absolutely. So Karen, coming back around to that and engaging with an administration, engaging with members of Congress, and having these conversations, why is it sometimes so difficult to get them to understand that the right thing is the right thing?
Well, I think that part of it sometimes is just being able to put things within an informational type of context, right? So members of Congress, I've worked at the state level now more recently within more public health realms, is really being able to transcend what is it that AHA is saying, what is it clinically that we're saying to legislators, to policymakers that make sense, so that then when they communicate with their constituents, They're representing the needs of the constituents, but they also understand what does cardiovascular health, what does cardiovascular disease mean in the population that they're supposed to be representing, right? Their constituents are going to say, I can't access health care. I had a heart attack. I had a hard time paying my bills. That's just the lay language that they're going to be using, right? So then the legislator really needs to be able to understand, what does that mean? How can I maybe have a conversation with that hospital administrator, with that health system, with these doctors, with this medical association, so that then my constituents are much more protected from cardiovascular disease, know where to access information, know how to pay their bills, know where to get medications, et cetera, so that then I have a more healthier populace at the end of the day.
Yeah, so at this point, I want to open it up. If anyone has questions, I mean, these are real experts in the field, so I want to make sure. Yes, we got one right up front. I love the first question. I love the person who has the, I saw this hand.
Go.
All right, they're excited.
Hi, my name is Natalia. I'm the CCI PepsiCo Nutrition and Health Graduate Fellow, and I'm also a registered dietitian. And Dr. Sanchez, I just want to thank you for the comments on culturally competent nutrition and movement. Nutrition research in the field of dietetics is very Eurocentric, and our foods are often demonized when it's just as nutritious. And this can go for anyone on the panel. However, there was a lot of talk regarding obesity, and I want to be a weight-inclusive practitioner, especially when weight management leads to disordered eating and eating disorders and is deeply rooted in other issues. Do you believe or know weight-inclusive methods that help promote heart health in the community?
I'll jump in only because just yesterday I was speaking to a group of students, dietetic students by Zoom in San Marcos, Texas, and got asked the same question. I don't have an answer of who's doing it, but I do think that the notion of weight-inclusive care is all about, cultural humility, and it is all about meeting people where they are. I think, and creating the environment where the conversation can be had about you can start with the Life's Essential 8. Each of them is important, but you don't have to have all of them under control all at one time. And if you're good on most of them, that's better than being not so good on most of them. And then in that relationship, as you are with a team taking care of a patient, you figure out where is that going, and where's that going, not in a negative way. I had many patients that became my patients with the caveat, that person will never ... And I'm here to tell you that person did ... Whatever that ... is, I worked with people, and we worked together to kind of figure out what was the right thing for them. So I think weight inclusiveness is no weight shaming, no just focusing on the one thing, remembering that cardiovascular health is 8 different things. And again, if you're good on 7 and not so good on 1, that's pretty good. You're doing way, way better than most people. So I hear you, and we've got work to do. So part of this also is taking fear and hate out of care and making it about love, compassion, meeting people where they are.
Absolutely. Magnus, I know you wanted to add something.
Yeah, so I think where things have gone a little awry with the high BMI or the high body mass index is the fact, just what you said. We said, well, it's all you. Well, now science actually tells us that there's much more to this. Actually, obesity, to some extent, is a disease, like many other diseases, that needs to be treated and needs to be managed. Yes, diet is fundamental to that. No going away from that. But we now also understand that the signaling in our bodies are making us gain weight, no matter what we really do. And some people are affected more than others. So for us, the transformation that happened here was that we took away this sort of shaming and said, there's more to this. There's science behind this. And so from our perspective, we need to work on that in the most informative way. And I'm not saying diet is going to go away. It has to be there. But there's much more to this. So stay tuned. The science will come to you soon.
Wonderful. We had another question over here.
Is it on? Okay.
Yes.
Hi, my name is Karina Yanis. I'm the CHCI Google Public Policy Fellow. I think this conversation is great, but something that always is in the back of my mind is like the intersection of health and a bunch of other issues. And I was wondering if, as health people, like if there's an effort to advocate for policy that ties, say, like labor and health, because you talk about the 8 stressors, and like a lot of that has to do with the way people work. Like if you want people to exercise, they come home, they're tired, they want to lay on the couch and watch TV. So even pushing for like a 4-day work week for people who work in factories, for people who work out in the fields, not just people who work in offices like us. Because like when I get home, I'm tired, but like I was sitting all day doing stuff with my brain, and there's people, and like I could go exercise. I feel like it's not that hard, but like I think about my dad who gets up to go to 4 a.m. shifts, and he gets home and he's tired, and he's not gonna think about exercising, and like he has diabetes, so like that would benefit him greatly. But I feel like we're asking a lot of people, and I don't want to take away personal responsibility in your own health, but there are a lot of structural issues that aren't addressed when we're talking about health. And I was just wondering, in your advocacy, do you ever try to tie that to other issues like labor specifically?
100%.
I'm going to jump in and say one of the things that makes me proud every single day to work for the American Heart Association is that sometimes it says tough things. And there is a 2020 presidential advisory, a call to action, structural racism as a fundamental driver of health disparities. And what it lays out is a call to action. Let's find what those things are that are those structural inequities and begin to try to address them. Specifically around labor, I can't tell you that we're doing that just yet. But we are talking about things like housing. We are talking about things like food insecurity that's entirely based on where you live or how much income you have. And I'm going to borrow some words, is that we didn't come to this just because we think this is how we ought to be thinking about these issues. The science took us there. The science is telling us that social determinants of health are among the factors that might contribute to persons having obesity or not having obesity. There's biological factors, there's social factors, and some of those social factors are influenced by structural factors. So I would say, just to repeat the words of another panelist, more to come.
I would also add too is that, I've worked in public health, and what we oftentimes worked with was with employers. And we know that many of our Latinos work in factories and a lot of these situations where they don't have a lot of rights. And we've been working a lot within the public health realm to talk about worksite wellness, and not just wellness for individuals who work in offices, but really who work in a variety of settings and also have environmental or occupational hazards in order to make them look at other possibilities of what they can provide to employees, right? So perhaps finding more times throughout the day, if they can have time, like a 15-minute break, to take a walk, to take a break, right? They're not going to have access to a treadmill. They're not going to have those types of opportunities, but maybe there is a park nearby where employers can provide their employee an opportunity to just take a walk break, right? Not in order to be doing lifts or weights or anything like that, but those are oftentimes practical solutions from the public health lens that we've found with employers in these types of circumstances that are not often ideal in terms of getting a gym membership, because that's not realistic for many of our communities.
Amy, yes. I'm going to jump in and just say, because it's related to this. The AHA has a report. I'm just going to do a commercial for AHA. I'm just telling you here now. So, but this was done in partnership with many organizations, private organizations as well in the United States, driving health equity in the workplace, that takes what is being said and actually, in a report, identifies in that particular report 15 strategies that can make a difference. One of them, if we think back about COVID and the sorts of things that put people at risk, paid sick leave is one of the things that we believe is a health equity measure that makes a huge difference, protects people. If you're sick and you feel like you have to go to work, you may go to work and expose people. They're also going to get sick. So driving health equity in the workplace. Sorry.
Yeah, no worries at all. I know that we're coming close to time. I know we're getting close to our hour, but I want to make sure. Okay. Well, yes.
I want to do an advertisement for AJ2.
All right.
So one of the things.
We've got an admiration society.
Yeah.
Going
So
here.
why did we have the 8? The 8 factor, sleep. It's unrecognized that if you don't sleep well or you don't sleep enough, you gain weight. And so that's one more thing to think about. Now, yes, I know we want to watch all television shows and all kinds of other things at night, but actually cutting some of that out may actually help you lose weight, which is pretty novel. And that just tells us exactly science is changing, we're learning more.
Thank you. That's so important. And you're absolutely right that those social determinants of health are tied inextricably with all of that. And I'm sorry I have to cut you off, but I think the panelists are going to be here a little bit afterward if you want to ask some questions. But I want to make sure that we have a little bit of time here at the end to just make sure that each of you can just share with us your takeaways. Like if someone's walking away from the conversation and the 1 to 3 things that you want them to really take out of the conversation.
I would definitely say prevention is key. Prevention, we really need to inform our future generation, education, and really understanding what are our rights within the systems, within healthcare systems. I think that Latinos, we tend to be humble, we don't want to speak up. And really when it comes to conditions like cardiovascular care, we need to be our own self-advocate and we need to be informed at all times in terms of what indicators are out there.
I think you heard my voice. Check your LDL, check your cholesterol, check your risk factors. You have an ownership to this and you can modify it and you will do well. And as a practicing cardiologist, I love the idea that patients take an interest in their own health and making a difference.
Yes, I do echo of what my colleagues just mentioned. And again, I'm going to say the same thing I said earlier. I think it's important for family members and their caregivers to all be involved and keep an eye on their seniors' health for those that need help. And when talking about heart disease, we need to see this through a holistic approach. We all need to be in this together. And again, just as Magnus and I know eventually all my colleagues just mentioned about prevention, this is key to prevent cardiovascular diseases that unfortunately are impacting our older adults. And eventually we will all age. So we hope we can age with the best possible health and healthier too.
I'm the CMO for prevention at the American Heart Association. Second point, Magnus asked the question of how many of y'all have had your cholesterol checked. I'll bet you $1 million that the same group, if asked, do you have health insurance, would raise your hand. So if there was one thing that I think I would say we need to be advocating for, it's for expanded Medicaid in all the states that have not expanded Medicaid yet. 17 million Latinos, about a third of all Latinos live in Texas and Florida. And already you'd have millions of people with more insurance. And I promise you, the evidence is very clear. Having insurance is a higher likelihood that you will have your cholesterol checked, your blood pressure checked, your glucose checked, and have those under control. And then the second thing I'll just reiterate, we need a workforce that looks like this room. Because we can culturally competently train people, but at the end of the day, are they as culturally effective as a workforce that's more diverse, where somebody can call on the phone or know that they can get information quickly? And part of that workforce, I want to make real clear, includes promotores de salud. Community health workers have to be part of the healthcare team because they are that part of the team that can talk to and be in community and help folks overcome what might be personal barriers, but also begin to navigate healthcare systems and the systems and the communities that they live in. thank you, Amgen, for hosting this, and thank you for the invitation.
Absolutely. Thank you, Amgen. Important conversation. It stays top of mind. Check your LDL. Tell your parents to do it too. Everyone in your family. Look, we have to do it together. So thank you for being here for the conversation. Please help me thank our wonderful panelists.